I think in your experience, what's a typical time frame for seeing headache relief after decompression? Is there a certain time frame where you say headache relief isn't going to go away, and at that point, what do you do?
Well,
do you
I think many patients will wake up saying, you know, I just had brain surgery and my headache's gone. You know, but we tend to see patients who have good headache relief, and then 3 to 6 months later say the headache comes back. So we need to say, what is that? And oftentimes that is got to do with raised intracranial pressure, or for lack of a better term, pseudotumor-like processes, which need to be looked at. We were, began to do spinal taps, looking at intracranial pressure. The average, and that's been looked at. Dr. Keating, I think, talked about it. We've looked at a lot of patients, maybe 30% of patients after surgery have pressures that range above 230, 240 millimeters of water, which is clearly elevated. It's not going to give you a shunt, but it's still raised intracranial pressure. That may be aggravated by activities and the like. And so we tended to be, pretty aggressive about using Diamox, monitoring, bolting patients for pressure, and seeing, how we managed intracranial pressure that way. I mean, a shunt is the last thing you want to do for a patient because it's a labor of love and it's never ending. Pediatricians really that deal with kids with shunts know that it's a nightmare. The average kid with a shunt in his head after a year has 17 to 20 shunt revisions before they're 30 years old. And it's really agonizing. So we want to have a high threshold for putting a shunt in, but we want to treat those patients to manage intracranial pressure in some way. And hopefully good management of that mechanisms by way of looking at it. I mean, there are some new techniques looking at intracranial pressure by ophthalmologic techniques. We were, like to do LP studies and infusions, where we would, infuse, take spinal fluid off and then put it back in. And these patients oftentimes had difficulty absorbing spinal fluid, and that's usually where the problem is. After surgery, everybody makes about 1/3 of a cc of spinal fluid a minute. That's, in the course of a day, you make 3 times the amount of spinal fluid you have. The average spinal fluid space is about 150 cc's of fluid, and you make 3 times that much. So that fluid has got to be absorbed, and it's passively absorbed. It's passively absorbed through the granulations at the top of the head into the sagittal sinus and along some of the similar conduits in the spinal cord. About 10% is absorbed in the spinal canal. Most of it is absorbed within the head. But it's a passive, and that gets clogged up by chronic inflammation, blood in the spinal fluid after surgery. So if you've had 2 or 3 Chiari decompressions, you've had inflammation, you've had blood in the spinal fluid, all of that can clog up these absorptive pathways. So for the most part, patients have poor absorption of spinal fluid, and that's a kind of pseudotumor in a sense. It raises intracranial pressure. When you look at the dynamics of pressure, when you decrease absorption, the spinal fluid pressure begins to gradually rise. And so it would be nice to have better strategies to medically limit spinal fluid production. Right now, there's not a lot, that we can do, and you need a close relationship with a neurosurgeon who's willing to monitor intracranial pressure with bolting and the like. They don't tend to do that. Neurosurgeons bolt patients when they have terrible cranial trauma in the emergency room. It's a little bit of a risky procedure. You got to, you have to make a hole in the skull and put a probe in the cortex. All right. So just to measure the spinal fluid, the other alternative is to put a needle in the spine, and a lot of people don't like to do that when there's a Chiari present. So you have to have good strategies to look at that, and hopefully we'll be able to develop ways by, there are some techniques people have been trying to do by looking at the pulsatility in the jugular vessels, by looking at ocular pulsatility to maybe measure, to looking in the ear, look at pulse waves in the ear to measure intracranial pressure in the posterior fossa. Those techniques, some of them have been looked at in Germany and in Europe. It's not been an area that people are very interested in the United States. And that's where we need to direct some attention so we can better monitor intracranial pressure.
Yeah, I'd be happy to work on that with you. Before I kind of ask a question about some syringomyelia specific stuff, there was a question that came in the chat about, can Diamox be used long term, and do the side effects lessen or worsen over time at all? Like,
well, the side effects are, sometimes tolerable, sometimes not. I've used Diamox effectively for 10 or 15 years, but the natural history of this is that it generally, the absorptive capacity may decrease a little bit, and patients either get through and get old enough, their brain shrinks a little bit, and they're copacetic, or they need surgery. So it's not something that works for everybody long term. And I would say, for the most part, patients may get some relief, but they ultimately come to surgery. It's just the nature of the natural history of this pressure-like problem and the frictional elements at the cranial cervical junction that lead to restriction of movement of spinal fluid.
Yeah.
So that's where the problem is. What do we do long term for this? Because oftentimes the medical approaches begin to fail at a certain point.
Right.